30 seconds.
Good evening, everyone, and welcome to the second episode of Wellness Matters. We are very eager to engage with you tonight, so make sure to post your questions and comments in the live chat on both Facebook and YouTube. Cardiovascular diseases, which are a group of disorders related to the heart and blood vessels, are a leading cause of death worldwide, taking an estimated 18 million lives each year. That is 30% of global deaths. In the United States, every 40 seconds on average, an American will have a heart attack, according to the American Heart Association. In the Middle East, 34% of deaths are due to cardiovascular diseases. Therefore, it is of utmost importance to create awareness and to understand those diseases and their risk factors, such as high lipid levels, hypertension, diabetes, and obesity. Tonight, we are going to try to break things down for you, focusing on two of the many heart diseases out there: aortic valve stenosis and atrial fibrillation, with Professor Firas Alani, a consultant cardiologist at the American Hospital in Dubai, who is also the Chief Medical Director of the Heart and Vascular Center. He is also the chairman of the American Hospital Academic Institution. Dr. Alani received the rank of full professor in cardiology from the Central Michigan University College of Medicine in the US. Among his many fellowships is one in advanced structural heart disease from the Henry Ford Hospital in Detroit, and he has American board certifications in 6 different medical disciplines. Professor Alani, thank you so much for being with us this evening.
Thank you very much, Faya, for your kind introduction and the warm welcome. It's my pleasure to be here.
We are very excited to delve into the topics for today, even though they might be a bit complicated, but we are going to try to break them down.
Yes, we are.
But before we begin, let's start with something a bit more general to explain cardiovascular diseases in the Middle East specifically. What are the most common, and at what age do they usually manifest themselves?
So cardiovascular disease, as you pointed out, is still the #1 cause of death internationally and globally, and the UAE is no different than the rest of the world. It's still the #1 cause of death. When we talk about cardiovascular disease, as you mentioned, it's a global of diseases, and specifically we're talking about coronary artery disease, which is blockages in the coronary arteries. Now, in my experience, and I can contrast experiences both in the United States and here, and my 15 years of practice, I can tell you what I've noticed difference between this region here versus the rest of the world is that the prevalence of coronary disease tends to occur in an average age of 60 to 65 where I practice in the United States. Since I moved here, and it's been about a year and a half ago, I've noticed that there's more of a younger age population being involved and affected by this disease, and my patient's average age here is almost 40 to 45. So that is a very interesting finding and very concerning finding.
Now, what are the main factors that put someone at increased risk of heart disease, and why are men usually more at risk than women?
So the risk factors are the common players, are hypertension, diabetes, high cholesterol, smoking, and on top of that is family history of premature heart disease, which is very important. I think it's also, to add to that, is obesity or sedentary lifestyle, lack of exercise, and also just stressful lifestyle. Now, the other aspects of risk factors are important is really that has to do with all what was mentioned above. But it's interesting that you pointed out it is in fact that men are more commonly affected by this condition, although there is almost a dichotomy that happens towards the later age population, and there's a catch-up phenomenon where we see in the late 60s and early 70s there is more prevalence of coronary disease in women than in men. And that's always been a debatable and hypothesized situations where no clear understanding or explanation to it.
What I find also a bit weird is the fact that in certain countries where they eat a lot of saturated fat, which is usually associated with heart disease, you notice that they have the lowest prevalence of heart disease in the world. For example, France. So how can you explain that?
Well, I think there's a lot of that has to do with genetics, and a lot of that has to do with lifestyle, and I think, and also overall sedentary lifestyles. I think in Europe in general, I believe that people are more inclined to exercise and moving. We see a lot of people commute using bicycles and walking, and I think in our region and in general, and in the Middle East as a whole, there is a common theme of sedentary lifestyle. And I think the lack of exercise and maintaining a sedentary lifestyle, in my opinion, has a major role in that difference and why we have more prevalence, despite eating less cheese than our friends in France.
Now, another factor that is also of interest is the link between heart disease and stroke. I mean, we hear so many people, let's say that he survived the heart attack, but then only to die, unfortunately, a few days later of a stroke. So what's this link?
So the link is very strong, and it's been adopted by and confirmed by multiple population studies, and really it goes back to the basis of the atherosclerosis, which is the disease that affects the arteries. And the arteries of the brain are no different than the arteries of the heart. They're no different than the arteries of the kidneys, and they're no different than the arteries of the legs. So when you have problems that has to do with arteries, atherosclerosis, that has to do with the system in general, I think you can see that this is more of a systemic disease, and therefore the risk factors are shared by these patients, by these diseases or these vascular beds. And it's not uncommon to see patients who have coronary disease have coexisting other atherosclerosis in other vascular beds, including the brain arteries.
Now let's delve into the details of today's topic, atrial fibrillation. Can you first start by defining what it is and how serious is it?
So atrial fibrillation is a quite common condition, and it usually affects people in their elderly, and of course the older the population, the higher the prevalence of the disease. What atrial fibrillation is basically a chaotic electrical disturbances in the heart rhythm, and there's really no
we have an image,
pattern.
I think, doctor, here that you can actually refer to.
Yes, I think we have an image of the atrial fibrillation. Basically, it describes how chaotic the rhythm can be, and creates almost so to speak, is an erratic rhythm of the heart, where the top chambers of the heart starts to fibrillate, and it doesn't beat in a synchronized fashion, and that causes a lot of problems, and specifically that has to do with flow and how efficient the blood flow within the chambers of the heart.
Which is exactly what we can see on the second one.
Correct. Which is the image on the right is where the atrial fibrillation is depicted, while the image on the left is a normal heart rhythm is depicted.
Now, AFib can also be occasional, intermittent, and permanent. So can you explain the differences?
The differences between these three types is really how frequent that condition stays and goes or persists. So atrial fibrillation starts with an intermittent appearance, where it comes in for a few days and then it disappears and then comes back in. And then it progresses to a more persistent, where it stays in now for weeks, and then it converts back to normal sinus rhythm, to then finally end with a permanent atrial fibrillation, where the patient is in atrial fibrillation 24/7.
Now, obviously, also, what are the symptoms and complications of such a disease?
The issue about atrial fibrillation, I'm glad you asked that question. It's a very insidious disease, and I always share this with my patients. It can be very sneaky, and I say this because there is really no clear symptomatology. The only thing that patients might feel is a general feeling of fatigue and tiredness. Sometimes if the atrial fibrillation becomes too fast, that patients can develop a sense of palpitations, but not all AFib are fast. So a lot of atrial fibrillation patients can have no symptoms at all until the biggest complication that happens, which is stroke.
Which brings me to the next question. How high is the risk of stroke with AFib?
So that actually has been calculated based on a score that physicians apply, and it's called the CHADS-VAS score, and it's an acronym of 7 factors that play a role in the that gets collected almost like a point system, and an atrial fibrillation patient gets given a score based on the coexisting of other comorbidities such as congestive heart failure, hypertension. Age is a big factor. Usually if a patient is above 65 versus above 75, obviously the older population have a higher risk. And when you collect that CHA2DS2-VASc score, that number then correlates with the risk of stroke per year, and it's accumulative. So, for example, if you have a CHA2DS2-VASc score of 3, your risk of stroke a year could be in the range of 1.2 to 1.4, but that's per year. So you talk about after 2 years, that 1.2 becomes 2.4, and after 3 years, it becomes 3.6, and so on.
Now that's a bit complicated, I think, for viewers to understand. But so if we want to, like, say in terms of percentage, if you have AFib, what's your risk of developing a stroke?
I would say the more comorbidities or other illnesses you have coexisting with atrial fibrillation, the higher your risk of stroke is. So if you have only atrial fibrillation without other diseases, that gives you the lowest risk of stroke, versus somebody who has atrial fibrillation and other causes. It tends to interplay with the atrial fibrillation and raises the level or the risk of stroke per year.
So usually when a patient comes to visit you for this AFib, what are usually what is he feeling? What are the symptoms? And how do you diagnose him? How is he diagnosed?
So from a symptoms standpoint, as I said, they're really not always clear, but sometimes they feel a general feeling of fatigue and tiredness. I think that's the most common symptoms we feel. Palpitation is another one, where they feel the heart fluttering, tends to occur at night or tends to occur in the early hours of the morning. And then the diagnosis is really doing a simple ECG, electrocardiogram. And once you do the ECG, it's very evident that the patient has or does not have AFib.
Now let's talk about treatment. So some of the treatments are surgical mostly, but can you explain what are the possible treatments involved?
Sure. So the way to describe atrial fibrillation treatment, I would describe it in two different silos. The first silo is really more of a controlling the rhythm and getting them back into a regular rhythm, a regular synchronized rhythm. And that has a host of medications that can range from just controlling the rate to a slower rate, or just converting the rhythm from atrial fibrillation to sinus. The second silo of the treatment of AFib, I think, is as important, if not more important, and that goes along with the prevention of stroke. We have to understand that the AFib is a big risk of stroke, and you pointed this out in our early discussion, and that's where the second and I would say a very important portion of the therapy has to focus is how do we prevent stroke in atrial fibrillation. And strokes from atrial fibrillations tends to be very large strokes and have a large impact on a patient's overall morbidity and even mortality.
Now, one of the procedures for treatment is the Watchmen. Can you explain that procedure?
So to delve into the Watchmen, I would start by explaining why stroke happens in AFib. Now, as we said earlier, when they have the heart fibrillating, there is a lack of efficiency in the normal flow of the blood. And as a result, there's an area in the heart, or in the heart itself, and not to get too much technical, it's called the appendage. It's almost like a dead space. When your heart is beating in a synchronized fashion, meaning there is no atrial fibrillation, that pocket that exists in the heart is not a big deal because blood goes in and goes out easily. But when you have atrial fibrillation, that pocket becomes almost a cul-de-sac, or an area of a blood accumulation. And if I may ask you kindly just to pass me the model.
Okay, so let's explain it on the model.
Thank you. So as you can see in the model here, this is the model of the heart. These are the two ventricles. Over here are the two atria. And this is the area where you can see the appendage exist, and exactly this little pocket. So if you ignore this little metal piece for a second, this area right here is the appendage. That becomes the source of blood pooling, and that becomes the source of blood. And we all know when blood stays in one space, it clots, and then clots can go all the way to the brain, and where the left atrium has a direct access to the brain. So the treatment of atrial fibrillation is blood thinners. Now, where does the Watchmen come into play, which is this device right here? Blood thinners come with a price, and unfortunately a lot of our patients with AFib who take blood thinners, yes, they prevent stroke, but they can have bleeding either in the brain or bleeding in their gut, in the gastrointestinal tract, or in the bleeding with urine or bleeding from the nose. There's a lot of bleeding complications. And those patients, when you stop the blood thinner, the bleeding stops, but then the stroke occurs. The Watchmen device is a new method that's been adopted to offer these patients a one-time implant that we actually go inside the heart in a very simple, minimally invasive procedure, where we can go from the groin, a small tiny incision, get into the right side of the heart and cross into the left side and deploy a, you can say almost like a little plug, and I have a little example of this right here. It's really at the size, you can see this is a real size plug, if you don't mind.
Yes, sure.
Thank you so much. And this is really the size of the Watchman, where it actually sits inside the left atrial appendage and seals that appendage and completely isolating it. With this in place, usually after 6 weeks, tissue will grow over it, and now that pocket we talked about is no longer existing, and patients will not need to be on a blood thinner for the rest of their life.
So it would look something like this in the heart?
Exactly.
Okay. So what's the rate of success of this surgery?
So the rate of success of surgery is anywhere from 98 to 99%. It's a very simple procedure, minimally invasive, requires general anesthesia, usually an hour or two tops. Patients go home the following day. It's done entirely through the groin, a simple nick in the femoral vein, and within an hour the patient is recovered from anesthesia. We usually keep them in the hospital for 1 day, and then they go home the next day. And they don't have to worry about blood thinners for the rest of their life.
And is this a lifetime, like you do it once in a lifetime, or do you need to change this plug?
Once in a lifetime. This is a one-time procedure, and this is what I tell my patients. Think of it as a one-time procedure that takes the role of a blood thinner without the need to take the blood thinner and all its repercussions for the rest of their lives.
Now moving on to aortic valve stenosis. It is one of the most common valve problems, but it's also very serious. So what are the main causes?
Aortic stenosis is one of the 4 valves in the heart. And the aortic valve, I should say aortic valve, is one of the 4 valves in the heart. And aortic valve stenosis, and I want to say that out of the 4 valves, it's the gateway out of the blood outside the heart. So it's probably the most important valve out of the 4. When you have narrowing in that valve, and that could happen due to multiple causes, and we can talk about congenital, but these are rare, but the most common cause of aortic stenosis, which is narrowing of the aortic valve. Think of it as the door where the blood exits the heart, and if that door does not open, the pressure on the heart becomes very strong. Most common cause is calcium deposition. And
let's see the images, doctor, and then you can maybe explain them as we see them. I think this is just...
This is the echocardiogram, and I think if we can share the image of the calcified aortic valve.
Yes, I think we need to go back to image 2 about the aortic valve stenosis, which will show the different valves, a normal valve versus an abnormal one.
So as I was saying, that when you have calcium deposits, which happens with age, the aortic valve leaflets, which are the 3 curtains that govern the valve, as you can see in the column on the left, the aortic valve in a closed position up top left, and then it's an open position in the bottom left, and then in the middle row you have a stenotic aortic valve, where it doesn't, when it's in the closing position, doesn't show up, but when it's opened, you can see the difference between an opening of a normal valve versus an opening of the severely aortic valve, stenosis. The third column is another problem that happens with the valve, which is now a leaking valve. Now the valve, as I said, can open and close. It could have a problem in the closure, which is the narrowing, or you could have a problem in the in the opening, which is narrowing, or a problem in the closure, which is a leak, where the valve closes but doesn't close firmly, and some blood leaks back into the left ventricle. That's called aortic regurgitation, while the middle column describes aortic stenosis.
Now, most of the causes, as you mentioned, include calcium buildup. That's probably the most common cause of this.
Correct.
But also rheumatic fever, even though it's not so common. Maybe we can touch upon very quickly on those causes.
Actually, rheumatic fever is common, more common here in the region than it is in the Western world. So I would say if you look at geographically speaking, aortic stenosis causes in the Western world is mainly senile aortic valve, which is calcium deposits, and that maybe constitutes about 90-95%, and the rest are, the 5% is congenital or rheumatic. When you come to regions in the Middle East, I would say the rheumatic constitutes about 20% of aortic stenosis, and then the rest is senile calcified aortic valve.
Now, what happens if it goes untreated?
So, as the natural history of aortic valve aortic valve stenosis is kind of long, and it's a process, as you can think of. The etiology of it is calcium, so it can take up to years with no symptoms. But the moment the symptoms starts to occur, Maya, is really when the problem starts affecting the patient's life, morbidity and mortality, basically lifestyle, and more importantly, livelihood. And those three symptoms can be described into three main categories: shortness of breath on activity, or syncope or fainting or near syncope, and then third thing is chest pain. Once these three symptoms, one of these three symptoms, starts to occur in a patient with aortic valve stenosis, it is time to fix the valve.
And it's usually common with old age, right? It's not common in younger patients.
Correct.
Okay. Now, how fast does it progress? If we want to just like sort of specify a time frame.
I would say it takes about maybe anywhere between 10 to 15 years when it first starts. But then it accumulates towards the pointing, because you can have an aortic valve stenosis that's not severe. And I think most of the symptoms, we need to link the symptoms mainly is usually with severe aortic valve stenosis. So when we actually evaluate an aortic valve, and we'll get into the diagnosis, which is a simple echocardiography, you can actually put the aortic stenosis into three buckets, so to speak: mild, which I call the simple, or small in layman terms, or medium or severe. And severe aortic stenosis is really where the symptoms. So back to your question in terms of latency, you really could take up to 10 to 15 years to get to that level of severe AS to then have symptoms.
Now let's talk about treatments. Is it only surgical, or is there any medication that can treat this?
So once you have a tight aortic valve, it's a mechanical problem. And the only fixing for a mechanical problem is to fix the problem itself. There's really no role of medicine or medications in aortic stenosis. Once the patient becomes symptomatic from their severe aortic stenosis, the only solution is to replace the valve. Now, traditionally, aortic valve replacement surgically has been the method to apply, or has been historically the best method, where the patients would undergo open heart surgery. They go through a major open heart surgery, they remove the old valve and they put the new valve, and it's the recovery from there could take weeks to months. With the invention of the new technology, and we're very fortunate to live in this time or this era of new technology, now we have an option that is minimally invasive, where you can actually replace the entire valve completely from the groin all the way through the heart by putting the valve in there in a very minimally invasive procedure that takes up to 2 hours or maybe less, and the patients can go home the next day. And more importantly, Maya, that these procedures now are done without general anesthesia.
Oh.
So you can do this with simple conscious sedation, and the patient is sleeping, but it's not a general anesthesia, and they go home the following day or two with a widely open, normal heart and normal valve, and enjoying the rest of their life with their loved ones.
So let's actually explain this procedure. I think it's called the TAVI procedure.
Correct. So the TAVI procedure, or the TAVR procedure, these are the two versions. TAVI or TAVR is transcutaneous aortic valve implantation, or transcutaneous aortic valve replacement. And it's a simple, minimally invasive procedure, and maybe simple is more of a broader term, but I would say it's a minimally invasive procedure that involves interventional cardiology, or a team of cardiologists, including interventional cardiology and a heart surgeon, to go through the groin. Simple incision, takes about the hole is about 3 to 5 millimeter in diameter, where we can get access from the right artery in the femoral artery in the right groin or the left, and get all the way up to the heart, deploy the valve into the aortic valve position, and then remove the catheter and stitch the point of entry.
I think we're seeing an image. If you can just explain it.
So you can see on the right, on the left of the screen, this dotted line is where it kind of describes the pathway of the catheter. and in the middle image you see the access point, and in the image to the extreme right you see the valve in place. And I do have a model that I'm happy to share with the audience and yourself as well.
Okay, great. So if we can have a look at the model. Okay, doctor, you can go ahead.
So again, this is a different model of the heart, not the one with the atrial fibrillation. And you can see here, again, just to orient the audience, this is the left ventricle, this is the right ventricle, over here is the right atrium, and over here is the left atrium. Now in here is the diseased aortic valve, and I'm just going to remove it just for education purposes. And as you can see, this valve is very tight. This valve is calcified, it doesn't open normally, and you can imagine how much pressure this ventricle has to go through to overcome this tight valve. Now what we do with the aortic valve replacement, we actually come down from the groin and get into the aorta right here, and get kind of in a retrograde fashion back into the aortic valve, which is the diseased aortic valve. And while we are inside the diseased aortic valve, we can replace a brand new valve that sits inside the aortic valve, and it sits right in this area right here, and now you have the new valve sitting inside the old valve, and you can see how the new valve is completely open and healthy, and does what a normal aortic valve would do.
Now, how fast is recovery from this procedure?
So the recovery from this procedure takes about an hour or two. Once they are done, this is done in the cardiac cath lab. This is not done in the OR setting. And as I said, this is not a general anesthesia. It's a local sedation with some sleeping medicine. And usually patients will go home within 24 to 48 hours.
But what about post-surgery?
So that's the thing. We don't call it surgery.
Ah, okay.
It's a procedure, and that's a very good question. The beauty about TAVI is that there is no open wounds, there is no surgery, there's no recovery, there's no rehabilitation. Patients will go home the following day. Yes, they might have to do some local rehab just because of their debilitated state that led to their severe stenosis, which led them to the OR. And this is, I just want to show this last picture. This is actually the size exactly of the real aortic valve that we replace inside the disease valve.
Very impressive, doctor. We actually have a question from our viewers on social media, and it's actually about atrial fibrillation. But what other indicators of stroke are there other than atrial fibrillation? So, very good question.
So stroke could happen from a host of factors, atrial fibrillation being one of them. You could have stroke from a diseased or narrowing in the carotid artery, which is the arteries that supply the brain, and the two main ones are going to be on the right and the left. You can have narrowing in those in those vessels, and a small plaque could chip off the aortic of the carotid artery and go up to the brain and cause a stroke. Other rare causes of stroke can be congenital, such as hypercoagulable states, and these are patients who are born with a coagulability or clotting disorder that tends to develop, and then that clot finds its way into the brain and causes a stroke.
But stroke is usually not common among the younger population.
Correct, unless there is other congenital factors. One of them is a patent foraminovalle, which is a hole in the heart. That can be a cause of stroke. That tends to be the cause of stroke in younger population. And also what we talked about, the congenital heart disease. Short of these two factors, stroke is usually a disease of older population, not younger population.
Dr. Alani, thank you so much. It was very interesting talking to you this evening, and you obviously simplified a very complicated topic this evening. At the end of the day, obviously, we can all live healthier lives by eating better, exercising more, and undergoing regular checkups. I know this is easier said than done, but in the end, it will definitely be worth your while. Before you go, don't forget to like and share this episode on Facebook and to subscribe to the American Hospital's YouTube channel. Join us next Tuesday at 8:30 p.m. as we delve into the world of obstetrics and gynecology with Dr. Tamara Al-Adhami. So come prepared with your questions and have a good night.